Okay, so next up we're going to talk about the biliary tract. The biliary tract can be a common source of problems. Patients having gallstones and pancreatitis and things like that are very common. It can be a little bit of a difficult anatomy to get images of just because sometimes patients have different anatomies. Sometimes they're in pain or they're obese or things like that. So getting practice and getting good at the anatomy is really important. Again, just like in the other cases, we're not going to spend a lot of time here now talking about technique and normal anatomy because it's my hope that with your background you already know those things. We're going to talk a lot about just decision making and look at some examples of pathology so that we can practice our hands-on skills in the lab sessions. So I'm going to skip right over imaging technique and let's just start off with a little bit about decision making. So we think about patients with cholecystitis, or we think they may have cholecystitis. So essentially we can do the emergency or the point of care ultrasound. So we can do our point of care ultrasound, and if it's negative, if they've got a normal looking gallbladder, there are no stones, we don't see any biliary duct dilation, and we don't see wall thickening or anything else, then they probably don't have cholecystitis, at least not acute cholecystitis. There may be some other biliary dysfunction that usually can be worked up later in a delayed fashion, but they probably don't have cholecystitis if there are no sonographic findings. If we just see stones and maybe we have labs that are normal and they don't look too bad, we can control their symptoms, then that can be kind of a further outpatient referral and workup process. If they've got abnormal labs or they've got difficult to control pain or persistent symptoms or something, then maybe they need a surgical evaluation, and maybe they need a surgical evaluation, or maybe they need admission to the hospital. But if they've got two or more signs like wall thickening or pericholocystic fluid, or they're just super tender and you can't control their symptoms, then they probably need more immediate surgical evaluation and probably admission to the hospital and kind of follow through on that plan. Now, I don't have a diagram for this, but I want to talk a little bit about pancreatitis because we do a lot of CAT scans, CT scans for pancreatitis, and in my opinion, and some of the literature would back me up on this, that it's not really necessary. If we can ultrasound these people, we can stage the imaging with ultrasound, and then if they have pancreatitis, a lot of times we end up doing MRCP anyway, so it really doesn't make sense to do an ultrasound, a CT scan, and an MRCP. So what I suggest and what I do in my practice is I will ultrasound them to see if it looks like gallstone pancreatitis or not. So do they have signs of cholecystitis? Do they have a dilated common bile duct or not? And that will help me decide, does this look like gallstone pancreatitis or not? And then generally I will look at the pancreas, look around and see if there's a giant pseudocyst or some obvious mass or something like that. But then those patients can really just kind of be treated and then wait for further imaging with MRCP when it's available. Because if they've got pancreatitis, whether it's gallstone pancreatitis or not, that's usually an admission to the hospital, and they can get further imaging with MRCP in the hospital unless there's almost no reason that a CT is needed unless there's some other concern that you're evaluating if they're otherwise pretty stable and not that super sick. So just quick reminders, again, not going to belabor this, but the normal gallbladder, we want to look for the liver parenchyma, and we see what it looks like here, and if we get that nice reasonable exclamation point, then we know this is the portal vein here. The portal vein is the key to helping us find the common bile duct. If we look along the portal vein and there's no other dilated thing with it, then there's no biliary duct dilation. Just an example here of transverse, we see liver parenchyma all around it, and we see a little fold in this case, but we see nice, crisp, well-defined, thin walls, and these are normal gallbladders. Jumping right into some abnormal examples. So here we just see tons of stones everywhere with these dark black shadows. We still see a nice thin, well-defined gallbladder wall, so that's a good sign. And hopefully we fan through here and see if the portal vein looks normal. Another gallbladder, these are more subtle stones, but we see this kind of smooth, rough, and then we see these shadows come down from here. So those are subtle gallstones. This is not sludge because it's shadows. Sludge does not shadow. If we see shadows, then what we're looking at are stones. But we still see a nice crisp wall. We see the portal vein here, probably the common duct here. It's not dilated. Obviously, we'll fan through there to be sure, but try to recognize gallbladder and portal vein every single time. Other examples, so here we can see the liver parenchyma, and we're right in the area where we think the gallbladder should be. It's a little bit difficult to see because it's full of stones. The stones go all the way up to the edge of the wall, and we see this just big dark shadow right in the expected area of the gallbladder. So know your other anatomy and your landmarks, and you'll be able to identify this and not be confused as to where's the gallbladder. I don't see it. You know where it is, you know your landmarks, and you can see the gallbladder filled with stones. Another example over here where we see stones sitting down towards the neck, nice shadow, pretty well-defined wall. Obviously, we would take a few more sweeps through that to make sure it doesn't have fluid around it or it's not thickened or inflamed or anything else. Now, these are examples of patients with wall thickening, and the first thing I usually notice is that the wall kind of loses that crisp, thin, bright white definition. So you can see the wall looks kind of smudged or blurred, and that's because it's inflamed. Same thing over here. We can see the wall is kind of smudged, blurred. There's probably a little stone in there, although we want to look through there some more. And just train your eyes to notice right here is the portal vein. See that? Portal vein's right here. Obviously, we're going to fan more through that to see if the common duct is dilated or not, but looks like portal vein, and probably artery and duct are right in here, and probably not dilated. Look through it some more to be sure, but get your eyes trained and practiced to finding gallbladder and portal vein when you're looking at the biliary tract. And then just notice the wall smudged, poorly defined, and if we want to measure it more than, say, 4 millimeters or 0.4 centimeters is abnormal. And we judge it mostly in the anterior portions. We don't really judge the wall thickness posteriorly because we lose definition. We get through transmission and posterior enhancement that makes the posterior portion of the wall a little bit harder to judge. So we always judge wall thickness looking at the anterior portions or the more superficial portions of the gallbladder wall. And just a lot of times people have trouble finding the common bile duct, but if you train your eyes and really practice yourself at finding gallbladder and portal vein, that's the biggest part of the battle. And then if you identify the portal vein, you look around it and see, is there a duct or an artery? Remember, the duct and the artery and the portal vein always run together. They make up the triad. And just for completeness of anatomy, we've got the spine down here, and this is the inferior vena cava. So make sure you know what all these big black tubular structures are when you're looking at the biliary tract. So find the portal vein. We often will rotate counterclockwise, fan up or down, have the patient breathe in, and hopefully help us find the common bile duct. With the gallbladder, it's all about taking the findings of the biliary ultrasound in the context of the clinical picture. Make sure their symptoms fit if you think they have cholecystitis. If they've got left lower quadrant abdominal pain and you're scanning through their abdomen and happen to find some gallstones, probably not related and probably asymptomatic. So always correlate everything with the clinical picture. Many people have asymptomatic stones. And also remember, there are these folks with biliary dysfunction who maybe we identify with HIDA scans, and that sometimes can be worked up down the line. You're not going to find that on ultrasound at all. So just remember, there can be biliary tract disease that's not sonographically visible. So just, again, going through this algorithm, like we talked about, you think they maybe have cholecystitis, you do your ultrasound. If there's no findings, then it's unlikely. If they just have stones, but everything else looks okay, and you can control their symptoms, then that can be kind of an outpatient further surgical workup. If they've got kind of worsening symptoms or their labs are abnormal, they've got more findings on ultrasound, like wall thickening or pericholocystic fluid, then maybe they need surgical evaluation and admission. And then just again, touching on pancreatitis, use point of care ultrasound to quickly rule in or out whether it looks like gallstone pancreatitis or not. Take a look at the common bile duct to see if you think it looks dilated. Look at the pancreas. I know sometimes you think the pancreas is difficult, but just scan, even if you can't find the pancreas itself, scan in the area of the pancreas, make sure there's not some giant mass or huge pseudocyst. And then those patients can then generally go on to follow up with MRCP imaging, and most of the time a CT scan doesn't really add much to their workup. That's pretty much it for the biliary tract. We'll do some more abdominal structures here next.